Hello everyone. The most common cause of intestinal obstruction in children younger than 2 years is intussusception. Let's study about intussusception in this video. Actually, what does intussusception mean? It's a clinical condition where part of the intestine invaginates or telescopes into its own lumen. Let's say the bowel contents are moved from one point to another with a peristaltic movement. It's a special wave-like movement. Here we have the bowel. It's the proximal end of the bowel and this is the distal end. Peristaltic movement moves from proximal end to the distal end. Let's say there is some disturbances. There is a traction point. Due to the traction point, the part of the bowel will be pushed into its own lumen. Let's say now this bowel is pushed into the lumen. The common place for intussusception is ileocecal valve, where ileum joins the large intestine. It's usually called as ileocolic, which means ileum and the colon. Sometimes it could be ileo-ileal, which means ileum invaginates into ileum itself. Sometimes it could be ileo-ileal colic. Let's say here we have the ascending colon and this is the cecum. Here we have the appendix. This is the distal part of the ileum. It comes and joins with the colon. Let's say this is the lumen. Now this part is pushed into the colon. Now it may look like this. This is the ascending colon. Here we have the cecum. This is the appendix. Here we have the ileum. Now the part of the ileum is pushed into the colon. So let's say this part is now pushed. So this is the lumen of the ileum, and here we have the lumen of the large intestine. Okay, due to some traction point, part of the bowel is invaginated into its own lumen. What are the traction points? Usually in the younger children, usually the intussusception is more common in 6 months to 2 years age. During this age, it could be idiopathic. Without any anatomical defect, it can happen. Another most common cause is enlarged Peyer's patches. Peyer's patches means there's a clusters of lymphoid follicles in the lining of the intestine. It's mostly seen in the ileum. When the Peyer's patches enlarges, it can act as the traction point. It usually enlarges with the recurrent viral upper respiratory tract infections and rotaviral acute gastroenteritis like conditions. In older children and adults, it's a different story. The cases are usually associated with an intraluminal mass or tumor. Sometimes it can be like polyp, Meckel's diverticulum, or intramural hematomas. These intramural hematomas are usually caused from Hennep-Schoenlein purpura. Once trapped, the invaginated segment is called as intussusceptum. The receiving segment is called as intussuscipiens. When the disease progresses due to the peristaltic movement with the bowel, omentum also will get trapped. Ultimately, it will become swollen. So, the lumen is now compressed with the swollen bowel. It will cause features of bowel obstruction. and the mesenteric vessels which supply the intestine will be compressed. So there will be less blood supply to the bowel. So it will cause ischemia, progressively infarction and bowel gangrene as well. When it's untreated at this stage, it will lead to peritonitis and bowel perforation, which is a life-threatening emergency. How do the patients with intussusception present to hospital? The classic picture is an otherwise healthy child who suddenly presents with severe colicky abdominal pain and vomiting. During the abdominal pain, the child will often scream and draw up their knees to the chest. Sometimes the patient may turn visibly pale. But there is a tricky part. In between these episodes, the child will completely be normal. So, the complaint of the mother is excessive intermittent crying of the baby. As the condition progresses, their bowel movements change. While the very first stool passed after the onset of the pain might be normal, but about 30% of the subsequent stools will contain blood and mucus. This is famously referred as the recurrent jelly stool, which is a pathognomonic feature of this condition. Clinical examination plays a major role in diagnosing this condition. During the palpation of abdominal examination, we can palpate as distinct sausage-like mass in the right side of the abdomen as the peristalsis push the bowel towards the right upper abdomen. Sometimes we can feel empty RIF region. During the perectal examination, there will be mucus and blood in the gloves. Sometimes we can feel the apex of the intussusception. To confirm the diagnosis, we can take abdominal X-ray. It will show abnormal gas distribution and signs of small bowel obstruction. But the ultrasound is the gold standard for diagnosis. It reveals a classic Target sign appearance, characterized by a hypoechoic edematous outer loop of the bowel wrapped around a hyperechoic compressed loop of the bowel telescoping within. The management begins with basic resuscitation of the child and giving proper analgesics. For idiopathic cases in infants and young children, non-operative treatment is highly effective. The intussusception can be corrected using a pneumatic air enema or hydrostatic reduction under X-ray screening. The pressure will be applied to the invaginated part to get it to the normal position. It's critical to note that barium should not be used due to high risk of perforation during this procedure. However, surgery becomes absolutely necessary if the patient shows sign of peritonitis or perforation or if the pneumatic reduction fails. Delayed presentation is also a relative indication for surgery. During the surgery, the surgeon performs a gentle retrograde reduction, squeezing the apex out of its containing bowel rather than applying the traction to the proximal bowel. If the bowel cannot be reduced or it's already gangrenous, that section must be resected. The prognosis of this disease is usually good, but there is a risk of recurrence. Comparatively, the risk of recurrence is higher in the patients who are managed with non-operative treatment than the patient underwent surgery. Hope the video was useful. Thank you.